to make it like thematic, to make it like a story. And because my life has been full of projects, and it wasn't until you kind of really sit and reflect and how it all kind of does kind of weave a story. So it seemed to me like it was weaving a story about measurement and why we actually kind of measure things. So I am a health services researcher. I'm not a clinician, unless I'm looking in the mirror talking to my children. That's my only time I'm allowed to kind of give advice. So without further ado, I want to acknowledge my four main affiliations. I've been with CAMH, still affiliated as an emeritus scientist for 47 years. It's a long time. And also almost 11 years now with HRI. See Sid's here. And now at the University of Toronto, affiliated with Department of Psychiatry, most of the work's through the Dalla Lana School of Public Health. And then also, since retirement, I've created an entity called Virgo Planning to help organize projects and on a consulting basis. So this is the best I could do to weave this story along. What are the needs of the people in the community? What's being provided to meet those needs? Can we do better? Who's accessing the services we offer? And what is their experience? Is anyone getting any better? What's around the corner? And then what have I really learned? And then I did put in brackets so far because I don't think I'm quite done yet. And the interesting thing about telling these stories, it's not sequential over time. These are almost all overlapping themes in the work, which leads to a lot of travel and not very much sleep, I might add, over the years. No, I'm not going to start when I was born. But this is an interesting way to start the story. Is my mom. And she asked me, she used to call me Dr. Rush. She said, I know you do presentations a lot, and I know you write stuff, but like, what's your job? My brother's an engineer. And she never even had to ask him. Somehow she just knew. So if you say you're an epidemiologist, that goes nowhere. Health services, it's just not going anywhere. For years, it didn't go anywhere. So finally, I said to Mom one day, Mom, you know how it's like some doctors have patients? Yeah. I said, Mom, for me, the community is my patient. And it nailed it. I was so happy. And then in a way, I realized I was just summarizing public health and community health. So I thought I would start in honoring my mom. And then what are the needs in the community? I thought it was and this is about substance use and mental health, but primarily the talk is on substance use. So what the needs are not. And so historically, when I started back in 77, there was still a lot of leftover feeling that there was something really quite unique about, quote unquote, an addict or an alcoholic. And there was this division that there was them and then there was kind of poor them, a lot of stigma associated with that. And then there was all the healthy us. Well, that's just not the case. And there was a lot of work at the time based on that model of the them and the us. And then some of you will know Jelinek, who actually was he worked out a formula based on the them and us, because the them get liver disease and they die, and the us, we don't. So if you analyze the them with all this liver-related things, you can actually come up with an estimate of the number of them, and it goes something like A is the number of quote-unquote alcoholics, and this formula based on the number who've died and the percentage of those who've died from liver disease, da 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 da, and you get a number based on the them. Well, the needs of the people now are looked at quite differently. Thank you for so many people, many of in the room who have adopted this and worked on this. So we now know it's not a them and us, it's like all of us. It's all of us. And we have this risk continuum. And there's different versions of this, but then now, even back when I was getting started, we had this continuum thing, and we thought, well, maybe we can estimate kind of the them at different points along in the continuum based on the amount of alcohol consumed in the community. And so folks that I started with in my career, Bob Popham, William Schmidt, Reg Smart, some of you, Eric Single, some of you in the room will remember these folks, thought you could test the theory, and the theory was such that if you knew the average amount that each person was drinking, and you knew the total amount that was being consumed, you could actually estimate the number of people along this curve. Well, it's pretty mind-boggling how they did that. I'm going to test people, especially here in Ontario. How would you actually know back in the 60s how much people were drinking? So in those days, and this is even, I think, when I turned 16, you went to the liquor store and you had to fill in a slip with your name on it. So these guys got an entire year's worth of slips of paper with people's names on it and actually calculated how much people were drinking. And they plotted the distribution of consumption, and they found out that, yeah, you can actually estimate people along the curve. And the them, as it was still defined, was anyone who was drinking over 8 drinks a day, which was pretty cautious estimate at the time. But the implication is clear that if you can estimate the whole curve, you can now estimate the full continuum, including prevention. And this was a whole new paradigm. And so now we have, thanks to, I'll even click the next, thanks to Gord, we have the substance use health continuum. And it's pretty much enshrined. People are still not invested 100% in that language. I would encourage you to really think about it. If we think about mental health, we now have that whole spectrum of wellness to illness, and it's really the same with substance use. And so many of us have now adopted this term, substance use health, and it's a shout out to Gord. And then so now we have this new measurement perspective, and we come to the tiered framework, which is now a kind of like status quo in a way, but this is just a continuum of that, the continuum framework, but put in a pyramid where you have those people that we're used to seeing in the treatment context represent an important but smaller part of the population, and here's the rest. It's really just that continuum curve. But it also makes that point that if we're investing here in prevention, brief intervention, et cetera, then you can have an impact on the whole population. Back in the day, this is now getting into my own work in the needs-based planning work, which I'll speak to in a moment, we can actually estimate using survey data the percentage across this distribution. And I'd like to give a shout out to my colleague from Quebec who helped us in this work, Joël Tremblay. So then we move along, and then I think we even come to, I'll go back one, incorporating that same survey data, but then information drawn from the burden of illness, which gets us our continuum by disorder, continuum of risk, and we accumulate all of these data. The tip of the pyramid represents those with substance use disorders, which is again making the point that there's a huge percentage of the population do not meet those criteria, but do need services. And one last shout out to Daniel Vigo, a good colleague of mine now in BC that some of you will know, who developed this whole framework here. and we incorporate it into the needs-based planning. So then here we have the implications again in how we measure then starts to impact how we think about the system. And again, some of you in the room might remember the first national substance use treatment strategy that if I think I have Rita on the call. I was wondering if Rita would be here. And there were so many people, many who are still working in the field involved in that. But I wanted to give one more shout out to Rebecca, who's now the director of mental health and addictions in PEI, but worked a lot with us on this work. So we go from the measurement model to how it impacts our thinking of the treatment system and enter the tiered model, which now we're used to thinking. We even talk about, well, that's a tier 2 patient, that's a tier 4, that's a tier 3. It's kind of a common language that's evolved through much of this work. And this was the first development of that model. It's a little tiny to see here. Even without my glasses, I don't think I can see it. But it's who's eligible for service and aging problems, their share of the population, cost per person, et cetera. So you can spread out folks in this continuum. Doesn't look quite as pretty as in a pyramid, but the same point is being made that you can invest in the whole system. And this tiered model is now used throughout the system. And here's an example that we worked on in Manitoba. Anybody here from Manitoba? The infamous Virgo report. So this is how you use the tiered framework, organized by severity in the population and the levels of service. And here's cross-cutting services that should be available independent of level of severity, for example, screening and assessment, peer support, et cetera. So the measurement model starts to impact how we think about it, but also how we plan our services. And again, one more shout out to Kim, who's in the room, in terms of using the model, not just at the large system level, but in this case, planning a coordinated access system in one region of the province to make sure that that access system is touching all the pyramids in a practical sense. I also want to give a shout out to our Indigenous colleagues and folks across the country, because these tiered frameworks don't resonate. And I want to highlight the fact that they don't. And the first thing is that if you put a pyramid in front of people who work in the system, or almost anyone that I know, then it puts some people on top of another. And they just say, that diagram does not work for us. And so but also the way things are conceptualized, the language around DSM, et cetera, et cetera. So I want to just make sure in my presentation, I'm giving a shout out to one of our national leaders that I've worked with on many things. And I actually had the pleasure to work with Carol in developing some of this work many years ago. So second thing, what is being provided to meet these needs? Well, that's about how the system looks. So this is the problem we're trying to fix. And in a way, we're all trying to improve outcomes, but this is what the public sees. So what are we trying to do to solve that problem? Way back in the day, this has been a real retrospective for Brian. So some of you might remember Joan Marshman, who was the president of the Addiction Research Foundation. When she did this work, she published this after she kind of stepped down. But there was a big report called the Marshman Report, and it emphasized a few things: broadening the base of treatment, doing a better job of matching people to treatment, offering more case management, and really put in our face the evidence for non-residential, non-bed-based services, emphasizing the need to spread the continuum. Put this in context that most of the investment at this time is in residential treatment and in bed-based detox at the same time. So the key outcomes, there was a network of services developed, but most importantly for our purposes here, focusing on measurement and Brian's story, the Ministry of Health developed this addiction services policy, said we are actively going to implement more community-based services. And a shout out to our American colleagues that the same messages were coming through in the US. And actually, there was a really good reciprocal relationship between the researchers in the Addiction Research and Foundation at the time and the folks working on the same kind of thinking evolving in the US. And we had this really, really important report broadening the base of treatment at the Institute of Medicine. And then incidentally, about the same time, we have the first ASAM criteria, which are really articulating that continuum and the need to be matching folks. So a whole bunch of work evolves. Here's Brian being Dr. Rush and writing and summarizing. And through this time, there's a lot of really interesting developments between Europe, in the US, in particular with Robin Room and his colleagues. He was at Berkeley at the time. And this kind of a systems view, but you could also think of it as the social ecology of systems, of substance use treatment systems. So the way they evolve and shape and their connection to our way of thinking about alcohol and drug problems. And yeah, so we're busy. I think I also to shout out for Alan Ogborn, was one of my closest colleagues. I don't know if you remember Alan, some of you. He just dreamed of retiring and playing the piano, and he's still out there in Brockville somewhere playing the piano and being very happy. So I went looking for a photo of Alan, and this is the one I found. I was actually pretty happy because this is what he wanted to do. We did, just wanted to do a shout out here also for CRISM, which supported a survey. As a reminder, as I was going through these reflections, that these organizational surveys, they play a role. We need to talk to the patients, we need to talk to the families, et cetera, but studying the services is particularly important. We learned a lot in this survey. One, and I wanted to highlight this distinction, actually it was pretty good relationship between the existing withdrawal management system across the country and opiate agonist treatment. A pretty good relationship, in contrast to similar surveys in the US. And in this one survey, it was focused more on the cost of care. So they have people who fake being a patient, calling up the treatment center, and being enrolled immediately in a residential service with really no assessment, and very, very expensive. So this was the finding here. But the other study, and I couldn't show you because I reviewed the paper, it's not published yet, is that about 60-70% of these programs would not take anyone on opiate agonist treatment. And yet they were publicly funded. And it's something I've learned over time to recognize sometimes how far ahead we are of the U.S. In many ways, and we should feel good about that. Speaking of our U.S. friends, around the 1990 something, 95, we had this little problem here in Ontario where basically recruitment agents from the U.S. services, treatment services, were hanging around our First Nation reserves, hanging around outside self-help meetings and recruiting people to go to the States. Look at these numbers. By 1991, $36 million were being spent going to the United States for 6% of our treatment population. There was no controls. There was no mechanism. There was no pre-approval. It was a complete disaster. Well, over time, enough people got concerned that OHIP decided they needed a pre-approval process, and they created what's known as the Drug and Alcohol Registry of Treatment, which today is Connects Ontario. And I think because I had all this experience surveying the community and connected into the treatment centers, they said, Brian, could you develop that for us? I said, okay. And they said, you have 4 months. We had to rent the building, renovate a building, develop the computer system, hire the staff, train the staff, survey all the providers in the province. Nuts. Yeah, but I was made vice president for 4 months. It was people. It was great. People had to do what I said. I was pretty cool. So look, the impact we had. I always look back. This was a nice piece of work. So by 1992, 93, we were already down to like a tenth of the cost, and by 93, 94, we had almost eliminated. It's still there. There's still the need. We don't meet everybody's needs. But this was really out of hand, and it was a good part of my career. Connects is still going. I won't go through all the slides. They now have a gambling line. They have more virtual. It's a one-stop shop for people in Ontario looking for help, and I feel good that I had a contribution to that. I'm going to go through this part very quickly. This will show you the diversity now of the continuum of care. This is our national core services framework, which includes emergency crisis services and a whole host of categories. It includes a wide range of public health, including primary care, public health, et cetera, et cetera. This has been a shift in our thinking. It's now referred to as the whole of government approach, and the way in which we're really going to tackle responding to alcohol and drugs challenges in the community is if everybody is on board. So we have a whole range of community services and even more. I won't go through them all, but I just want to show you when we talk about the continuum of care, there's a lot of buckets in there, and they need to really be working together. We use this continuum, we use the framework to map the existing services onto the framework. And there's a lot of detail here. I'm going a little quickly. I'm concerned about time. But that mapping piece alone is very helpful. People do a gap analysis for their jurisdiction. We're finishing the project now in Manitoba and BC. So what's the evidence base? Excuse me. Here's a biggie. I'm going to look to Natty because Natty followed up and did a tremendous amount of work before and after. We could spend all hour or two, all afternoon talking about this process of integrating mental health and addiction, how it's gone, how it's not gone, what are our tools we're using, what's the way government has been reorganized, and does that really reflect how things are happening on the ground? This is a big national and international story. And the story's not done yet. I think I'll just say the story's not finished yet. Been involved in a lot of review of evidence, coordinated access, rapid access. You'll see a lot of this work I did was done in collaboration with a lot of different organizations, which I feel pretty good about. Can we quantify the gap? This takes us to needs-based planning. And it's a methodology for mapping out the whole tiered framework in a population. Could be Manitoba, could be Canada, could be a city, and identifying the level of need for each of those different core services. I'll go quickly again, but this model, we've been implementing it across the country for the last decade and a half. And people are getting more and more familiar with it. And I'll show you in a moment the kind of data that can come out. It's a process of engaging in a jurisdiction, estimating prevalence, and mapping the system, and gradually moving towards your estimate of what's required and the gap, et cetera. Here it is in context. You start with these tiered measurement of the level of need. Reminder that a percentage of these have substance use and mental disorders, mapping onto the framework, and had consensus panels that said this is for severe stimulant abuse. And the consensus panels were organized for each disorder and for each level of severity. And they mapped what people need. What's the care pathway at that level of severity? So these are consensus panels organized. Daniel led this work. What's the output? Estimated beds required, estimated FTEs in different categories. Becomes more concrete when you get here. So you have for a particular jurisdiction an actual estimate of the level of clinicians who are at a level for structured psychotherapy. The continuum of withdrawal management, you can see the number of beds that are required or where you may have an oversupply. Bed-based treatment, and also addiction medicine. So we've been implementing this and learning a lot. So back to the where we're measuring, it all comes from shifting your thinking about the nature of the problem and look how far you can take it to estimating the people and then estimating the level of need to a gap analysis to then help prioritize your investments. So this has been part of Brian's journey. I won't go down here other than to say, when you do this kind of thinking, you work within a jurisdiction, you say, here's the framework, here's the services, the core services, and then someone say, well, what's that? And this happened like a few years ago, like, what's mobile withdrawal management? Like, what is that? And then now you have an evidence base behind these things. And so you can talk to policymakers and talk to government and say, maybe you want to try this. So that the methodology becomes part of the conversation of system design. That's been interesting. Who's accessing these services we offer? Way back in the day, I developed DATAS, which is meant most of the provinces, all the provinces had some system for counting the people, if you will, and describing who they were and who's accessing services. Programs send in information, and I'll really age myself here because we started sending in faxes. Like, could the programs actually send us a fax once a month? And this is even before personal computers. Wow, it's a long time ago. But then, true to Brian has a way of getting involved in the small things become big things. So with CCSA, we helped out develop a national system for monitoring the services in the country, and then also in the EU. And I've been blessed by having all these different contacts develop around the world to kind of take the work that we're doing here. And I'm happy to say that typically we were ahead in many of these areas internationally. Example of different kinds of data. This one's interesting. I thought from an opioid point of view, if you look at Europe, it's kind of hard to explain why some where the primary substance of abuse would be opioids and others where they're not. So it's a value add of these information systems. They sound pretty basic, right? Let's count the people. They're not easy to implement, but they're essentially accountability. Like at least we should be able to show our funder that people are coming, right? We should be able to do that. And we should be able to count them, and we should be able to describe them. And this is the last information from DATAS, which is still going. Good work. Shout out to Karen Urbanowski, who's a colleague for many years, in her work on performance measurement. So using a lot of this kind of structured information to help guide the system over time performance indicators. Takes us to OPOC, and this is a good question. What is the experience of all the people coming? So this was another Brian track happening through 2010 to 15 almost, developing this perception of care tool. It was interesting. I found once I got into this literature, we shifted away from talking about patient satisfaction to their perception of what they're getting. And that was a really interesting shift because it kind of put the onus on us to be developing things that are supposed to work and that they should have a positive experience about that. Satisfaction tends to be very skewed. You get a bit different distribution in the data if you're, so well, what do you think about that? As opposed to, well, did it really meet your needs? It's interesting. So there are 8 domains in this tool: access, providing services, participation in rights, therapists, the environment, for discharge, residential, and 18. It's long. It's long. And then interesting development over time. This was back when we're really moving towards the integration of mental health and addiction, and there was no tool at the time that you could use in both sectors. So that was the purpose of this tool. We had a lot of input in its design. It was designed for QI. We now have what I call the OPOC kids. There's a tool for family, there's a tool for supported housing, forensics, and crisis. So big piece of work. I found this interesting last week. I was checking in to see how is this going. We now have between 175,000 to 200,000 records in the database. But I think more importantly, people are still sending it in and they don't have to. I found that really interesting. Like, it's voluntary. It's like it's a sign that this is being helpful. But I wanted to bring a bit of data here that, working with Jean and others at HRI, the relationship between the perception of care and outcome, because we don't have much of that. We have all kinds of client satisfaction tools, and we think of them as a proxy for outcome. But is it really a proxy for outcome? And the answer is yeah. In this project, we were using recovery measures, recovery-oriented outcome measures, life satisfaction, hopefulness, quality of life. And most of these domains, in this case, all of the domains were related to, this is 3, 6, and 12-month follow-up connected to their perception of care during the program. There's almost no data like this anywhere. So you can see we've highlighted in yellow, there's a pretty strong relationship. But interestingly enough, the domains that are most connected to outcome, by the look of it, are those domains connected to person-centered care. Were they involved in the program? Were they treated respectfully, et cetera, et cetera? So the implications were kind of interesting, that we could actually shorten the tool. Each of the subscales have been psychometrically tuned up, and you could use individual subscales as a proxy for outcome or for QI. And the one measure, a 3-item subscale, was an excellent predictor for outcome down the road. So this was a nice piece of work. Here's the real question, right? Is anyone getting any better? And the role of program evaluation, this is kind of the start of Brian's journey. And I started off here. Our first office was in London, Ontario. The main office of CAMH ARF at the time is in Toronto. So why'd they put this office in London? We're always curious about that. It was like a research center located at the University of Western Ontario. And we thought, well, so the organization could say, well, we're not all about Toronto. Actually, we think that's the truth. We thought we're kind of like, we're also invested in the community and we're out there. But so that's where I started. And from there, with Alan, began to get into the whole program evaluation field. This is back in 1980. There was no such thing. There was no textbook on program evaluation at the time. There was no staff in a hospital focused on program evaluation. It was something that happened in the federal government. Alan and I did a lot of developmental work, including the now infamous program logic models, and we published on that. But then an interesting journey started. Mario Favre, who was the director of our center at the time, he said, Brian, we've been invited. I said, he's been invited to do a training and evaluation in Frobisher Bay on Baffin Island. Would you like to do that for us, Brian? And I thought, no one will know if I screw up. That's actually what I thought. That's a long way away. So I developed a workshop. This before the internet. Like, no one would know how bad it was. So off I went, and it was amazing. I didn't see the northern lights, but I saw polar bears at the dump, And lettuce was $6 a head of lettuce at the time. I can't imagine what it's worth now. So this story starts to unfold. The more we got into the evaluation, we get connected to the WHO and realize, well, we're not alone in the world of addictions developing these evaluation tools. And I became a part of a project developing international guidelines. And that work evolved. So Brian gets on a plane, heads over to Geneva. People are invited to come from all these countries. Iran, which I developed a strong relationship with, from Brazil, remember Saulo Castel. Others came. Benicio Frey, who's now part of our kind of family at HRI. A lot of relationships developed there. So these are all the people coming into the workshop. And then, oh yeah, then we're done. And Brian has to go out to all around the world to do this training. I have to tell you, one of my interesting accomplishments, I have accumulated 1 million Aeroplan qualifying miles. I calculated that's enough to get me to the moon and back, and 3/4 of the way there again. That's a lot of miles. That's not counts what's on your visa either. So a lot of training. And these workbooks had all of these different sections, including one on measuring outcome, which takes us near the end of the story around moving towards what we're going to conclude on today is performance-based measurement-based care. So our first try at outcome monitoring was in with the now it's become CAM-H at the time, and we had two tasks. One was to develop a new screening and assessment package, which some of you may know. I'm looking at Reagan now; he's smiling. The GAIN, which has been out there and is soon to be decommissioned, but in concert with that, we had a project funded by Health Canada to develop a post-discharge outcome monitoring system. So now we're going to use all of that stuff from the logic models and all this training and say, okay, Brian, now you actually have to do it. You actually have to do it. So that was good. Well, we proposed, and we did find this is a lot encapsulated here. I think I want to give a shout out to Mike Dennis, who's really led the way in this work in the US and internationally. Number one, we found 1 year later, remember there's not much of this happens. This happens in clinical trials when you've got a lot of money to find people, but it's a very small number of people. This is capturing the system. Mike now has almost 150,000 people in an outcome database. It's incredible what he's done. But yeah, so people do improve, and then it's not easy. Jean and I often laughed, if this was easy, everybody'd be doing it. People are not measuring outcomes that far over time. And then, again, a shout out to you, Natty, for the work on the textbooks, the international, the chapter that I did a couple times on screening and assessment in developed countries. And this framework evolved, which I think is really interesting. One, notice the developmental age perspective. So the same kind of tools we're going to use for children, youth, or for older adults wouldn't necessarily apply. The tools need to be adapted, but this continuum of screening, assessment within treatment and post-treatment outcome monitoring is a connected system of measurement in support of, quote, measurement-based care. So this went on to enter HRI. And Roy. Roy was our first director at HRI. Roy calls me, this is about the time I retired. Roy calls me and says, Brian, we've never met, but I've been kind of thinking we need to know more about how people do after treatment. And I've been appointed to lead this center in Guelph. And do you know anybody who might know anything about outcome monitoring? Of course, completely knew what he was doing. And so Roy and I met personally for the first time, and we really hit it off. And I said, yeah, Roy, I'll be happy to support. And then comes Bob Ray. There was a board meeting. HRI has its own board separate from Homewood Health. And so there's Jean and I and a few others were in this meeting. And I was like, Bob Ray's been a hero of mine for a long time. And I'm going to meet Bob Ray, right? And Jean and I are presenting, and we're kind of impressed with what we're doing. We're talking about the recovery work that I'm going to show you in a moment. And then we're finished, and up goes Bob's hand. And I'm like, what's going to happen? And he said, could I ask you a question? He said, do you mean to tell me for all the time that I was premier, and I think he was the assistant, or appointed as the Liberal leader at the time federally, he says, do you mean all the money we've invested for alcohol and drug treatment? Do you mean to tell me we don't know if anyone is getting any better? A pin dropped. And Jean and I said, yeah, we don't know. I'm sorry to say, sir, we don't know. And if you stop and think about that, that's disgraceful. That's disgraceful. So here we go. We got on it. And this is the team that's been working away. This is the whole team. Some of Ahmed and Stephanie are here. And this is the kind of the group of us leading the way, but it's a big project. And there's people that I've come to really know and respect a lot through this process. So then what do we measure? So now we got all this going. What are we going to do? So we have ICHOM. It's an international organization that gets together to decide on standard outcome measures. Could be for autism, could be for depression, could be for eating disorders, could be whatever. They decided to do one on substance use. And yours truly was honored to be part of the panel, and we've recently published on that. So we had this experience to go by, but the most exciting thing about this project was when Jean, we all get together and say, well, why don't we ask the clients what to measure? Why don't we ask the clients? And so we developed this recovery journey project with a set of measures, and we won't get into details here. But we actually started to track people over time, a lot of support from within the organization. And then the next phase we're currently in, and Reagan's here, working with 6 different organizations to pilot and implement a performance outcome monitoring system called PALM. And the system goes through these different phases. And then after this talk, Jean and Ahmed and Stephanie and others were going to be presenting on the toolkit, the PALM project, which is implementing or providing support for organizations to implement this system. And we have the set of domains in there. And I promise, Ahmed, I wasn't going to steal all the slides we developed for the talk this afternoon, but only to say that it really is in the context of measurement-based care. That if we think of that continuum from screening, assessment, within treatment, monitoring, and outcomes, post-discharge, it's all in the interest of that. So what's around the corner? Another shout out. Some of you might remember Wayne Skinner, such a great colleague. And Wayne said to, we were in a meeting sometime, and he said to everybody, he said, if you want to know what's coming around the corner, just follow Brian. I thought it was so interesting. I've never forgotten that. And I didn't know if it was true. But then as I look back preparing the presentation, this thing from services to systems work, the work on concurrent disorders, the work we've done in outcome evaluation, and then I just wanted to relate to you my current interest, one of many, is in psychedelic assisted treatment. And it is around the corner. So I just wanted to give a sense of why that's happening today. That we have a treatment gap. We have many people not helped by current options. And the current evidence, it's not there yet, but it's growing and it's getting strong. And we have a legal and policy context that does include truth and reconciliation and the rights of Indigenous people, by the way. So what have I learned along the way so far? A life in service is a good life. That's the first thing that came to mind. And then, relatedly, we rise up by lifting others. And in your case, many of you, that's the clinical work you do. For me, it was lifting the community. Relationships along the way are critical to being successful and happy in our work. And those people who've gone, and also the new ones that arrive. And these relationships, I've been blessed through my work. And I think it's an important message I'd like to leave with everybody. The work is the work, but the relationships you form during the work with your colleagues and also with your patients is really important. Humility goes a long way. Context is everything, and everything involves, and it's important to honor those who came before. There's two angles here. One is I built upon a lot of people's work, and presently people are building upon my work. Some of it they're setting aside, some of which they're adopting. So part of the humility in your own work is to realize it's not going to be perfect, and somebody will improve it, and that's okay. But we need to remember who was really here and to honor the people who came way before us. And remember that we welcomed people and then we really hurt them. And I was so impressed with the opening prayer this morning to be reminded of that. And I reflect on this. To honor those that came before us, not just about our work, but the people who walked the land. And lastly, the most important and sustainable contributions are your own family and your own friends. So these are some of my colleagues who've left us too early. Some of them you might know. And some of it really lifted me up. Jürgen Rehm, Robin Room, Kim, Roy, my friend Clay at the back. Thank you, brother. And then those who arrived along the way. Life goes on. No, these are all new in my life, children of colleagues, children of research staff, etc. And then my closest support team, my God, I cannot do this. Even Jonathan was on the phone with me at 5 minutes to 2 this afternoon, getting this presentation ready. Honestly, Prapreet, April, and Jonathan are my right hands. And then all friends and family along the way. Amazing network of people that I'm so grateful for. Thank you so much.
Hi, I'm Ron Fraser, and I just want to give a short thank you to Brian. I met Brian a number of years ago when he was doing what Brian does, which was doing a program evaluation of mental health and addiction services in Nova Scotia, and in that process, meeting him for the first time, not just myself, but everyone was so impressed with what he brought to the table, with his vision, with his ability to relate to people, his ability to, identify the positives, but also help us to address where we could do better. And we were tremendously grateful. And it was clear when I ran into him this morning, there were so many people coming up, hugging Brian, congratulating Brian. And I thought to myself, we chose wisely. So thank you, Brian, for everything from all of us that are here and all of us that have come before. We tremendously appreciate your lifetime of invaluable contributions to the field of addiction. Thank you.
I get the idea that there may be a lot of interest in engaging with Dr. Rush. I'm not sure if he's got to rush off, but we do have a breakout room available if we can arrange it, room 202. So maybe just as people exit, we'll be a little more clear on whether or not we can do that. Anyway, thank you for attending this session.
Too much to present and not enough time. I'm sorry we aren't able to take questions. I'm sure Brian's going to be around, certainly for today, and I appreciate his interest. There are a couple of seats at the front. We had to guess as to what to put where, and there may be some transitions as people switch to other sessions. So if you're staying for the session on treatment of alcohol use disorder and depression, please, hopefully there'll be a seat for you, and we will move through that. And I'm pleased to present my colleague, Dr. Crockford.
Right, thanks for everyone attending. So Jen and I gave this talk at the Canadian Psychiatric Association meeting just last week in Montreal around it. What spurred this talk were the alcohol use guidelines that came out through the CMAJ, and there was things in it which didn't really jibe with clinical practice. I've been in practice for the past 26 years as a psychiatrist, seeing people long-term with alcohol use disorders and comorbid depression, and I'll follow them for a year, 2 years at a time, often on a continuous basis. And so I've seen thousands of people, and I saw the guidelines and they just didn't make sense to me. So we're going to go through a bit of that, hopefully, if this advances. There we go. Acknowledging the territory that we're on. And I think, I reflect on Brian's words and the words of the elder this morning. Both Jen and I have no financial disclosures. We're not, no affiliation with pharma in any sort of way. So that does not influence any of the things that we're going to be saying. We're going to go through a little bit about how do you differentiate a substance-induced depression from depression, like a major depressive disorder. It's interesting, though, when you really drill down on the data, a lot of the people who get called substance-induced depressions later get reclassified as actually having persistent major depression. But a lot of people still spend a fair amount of time trying to sort out diagnosis. The more severe the person has as far as an alcohol use disorder, the more severe the depression, the less likely it is that they're going to, it's going to convert and change over time. We'll talk about the management and then really sort of talk about, what do you do as clinicians? This is not an actual case. It's a conglomerate of people who I've seen over the last 26 years. But the example is Tom is a 46-year-old divorced male. He's a high-functioning guy, had an MBA, worked extensively in the executive suite. He was in the oil and gas sector. Alcohol really flowed freely. This is part of the norm in Calgary, it seems, with boom and bust cycles. But he was driven, held himself to a perfectionistic standard, bad-mouthing himself to motivate himself. Close friend suicided in his 20s, and he said, okay, that's it. I'm never going to contemplate suicide as an option whatsoever. However, his marriage started to falter in his 30s. He became increasingly disillusioned with work. His drinking started to increase. And then he started to notice in his 30s, late 30s, that he had an inability to stop drinking once he started, with cravings and continued use despite growing psychosocial sequelae, including that he eventually lost his job and he ended up on disability. He knew that he should stop drinking but couldn't. And then his mood also progressively deteriorated, where he had anhedonia, so inability to enjoy things that he used to, inability to fall asleep. He was waking up at 5 a.m. even though he didn't have to go to work. However, his appetite and weight were maintained, but he struggled with a lot of guilt, poor concentration, and loss of interest. He was on edge all the time. And he initially found that alcohol could help calm his nerves, but then it just seemed to persist no matter what. He remained quite, he could brighten up in conversation, but he would often be quite negative and self-depreciating in the way that he evaluated himself. His daughter had a history of major depression, but there was a family history of alcohol use disorders. So what you get from that story is that here's a guy who actually meets criteria for major depressive disorder, but he clearly also meets criteria for an alcohol use disorder. And then the question is, okay, how much is this could be related to his alcohol use? Like maybe if he just stopped drinking, it would all completely go away. And so over the years, these are the things which I tend to look at that give me kind of an idea around it. Sometimes timing can help to see whether if the depression began before or after the drinking, but usually the cases like Tom, where it's a mishmash, the both overlap, and that doesn't really help you too much. I used to do inpatients for years, and so during inpatient admission, people would have enforced abstinence and they would get better during that time. So that would direct me to say, okay, I need to focus in on their alcohol. Outpatient wise, it's a little bit harder to do that. Things which make me think that, I got a depression which I have to treat, and I should probably treat it early, is if the person has suicidal ideation, if I see clear-cut melancholic features, much like they look psychomotor slowed, so they look actually physically slowed down. They also will talk about things like early morning awakening, which is a real sort of flag. And then you look at what is the severity of it. So mild depression, some symptoms, probably I can watch, take my time with it. Much more severe, I got to be on it probably a bit sooner. You look for that overt loss of function. The other thing which comes up is women tend to present with depression and alcohol use more often than men do. Men drink a lot more, they drink more frequently. But if you have a woman who's coming to your office, you got to be thinking about, is there a comorbidity? Women often have really telescoped patterns. So when they start drinking, they get into trouble in a hurry, and it's often depression is one of the driving factors for it. And then if you hear this family history of depression, you always kind of wonder about that too. Epidemiology, and you've gotten a little bit of this today, is that, alcohol is a huge issue in Canadian society. 18% of people will meet an alcohol use disorder in their lifetime. It's one of the largest ones that we have. And if you are seeing a person with, say, a depressive disorder, a third to half of the time that they're going to have an associated alcohol use disorder and vice versa around it. Alcohol is the major cost to our Canadian society. 40% of that $49 billion that Dr. McKillop was talking about that's spent by Canadian society for healthcare, legal, and lost work causes is alcohol. And if you have an alcohol use disorder, you're more likely to have depression. The more severe your alcohol use disorder is, the more severe your depression is going to be around it. A lot of people who have alcohol as well as other substance use disorders have suicidal thoughts. If you don't drink, you have less likelihood of having suicidal thoughts, but also less likely if you don't drink to attempt suicide or to complete around it. If you have both disorders, you have a worse outcome overall. So hence the reason why you need to address both. And then there's certain groups that are disproportionately affected. So women, as I suggested before, but then people with racial and ethnic disparities. So we think about our First Nations people, they don't seek care. They don't tend to or not intentionally, but they often feel disenfranchised from the system, and they don't get depression care. And so you have to be particularly flagged that this might be going on. So the CMAJ recommendations 12 and 13, 12 was essentially, don't be prescribing SSRIs or antipsychotics for people with alcohol use disorders. They don't really treat them. There was way back when there was rat studies of SSRIs where all of a sudden rats consumed less alcohol if they were given an SSRI. And then so people said, hey, why don't we give this to people? But the conception was that alcohol use disorder was an obsessive compulsive disorder. It was the compulsion to drink, so therefore we need to treat it like OCD. In OCD, we typically would use high-dose SSRIs or other serotonergic agents. So then the thought process went, okay, well, let's put everybody on 40, 60, 80 of fluoxetine and see what happens with that. Well, you give people who don't have a depression or OCD a drug like that, you make them apathetic as can be. They're all restless, anxious, they feel awful. And then needless to say, they stop showing up, they have worse alcohol use outcomes around it. And I think this is where they kind of confused the evidence to come up with this idea that prescribing an SSRI antidepressant is not recommended for an adult and youth patients with alcohol use disorder, even if a concurrent major depressive disorder is present. And they claimed that this was a strong recommendation and there was moderate certainty of evidence to it. So to make a recommendation like that, based on the grade system, the strong recommendations suggest that most patients, clinicians, policymakers would support this action, and formal decision aids typically are unnecessary. So that there's wide consensus and the data is really sort of clear around it, and you need to do it because there's significant safety issues which are tied to this. However, what we're finding is, and what I'll go through quickly before I leave it to Jen, is that high quality RCTs are actually not really present for this. The majority of the findings are actually quite mixed around it. There is not a clear risk benefit finding with the data, and then a lot of the data does not sort of look at specific patient-centered findings. So we got mixed results, and then they cherry-picked which data that they looked at for these. So they ignored a series of meta-analyses, which I'll actually comment on next, which suggest that in fact SSRIs and antidepressants are helpful for this group, but they decided to go with only one meta-analysis instead. So the big one, initial one, was Francis Levin and Ed Nunes down in Columbia did a really good meta-analysis. And what they found was, the key finding was that antidepressant medications, including SSRIs, were efficacious for the treatment of major depressive disorder in the context of alcohol use disorder, with effect sizes similar to those seen treated, people with major depression who never had alcohol use disorder. And what they commented on was, there's a problem with a lot of the studies, is that when people come into the study, they would just sort of say, oh, I have lots of depressive symptoms, and those people got lumped in. But most of those people, once they stopped drinking, that a lot of them cleared around it. So there was a huge placebo response rate that you got that really obscured any sort of antidepressant responses. What we see over time is antidepressant responses or placebo response has consistently gone up. So now the placebo response in most randomized controlled trials for depression is anywhere around 40 to sometimes close to 50%. And so your ability to differentiate between drug and placebo gets really a lot narrower. The older studies, when we're looking at TCAs, which some people have suggested, the last TCA study which related to this was done in 1998. So we're talking about 26 years ago when I first started my practice. And that what the criteria that we used was DSM-3 at that time. DSM-3 differentiated depression as being melancholic or endogenous depression in those terms, and then exogenous depression, which was the way that the current lexicon of the terminology mostly describes, were excluded. And so you had people with severe melancholic depression who were highly likely to actually respond to antidepressants were the people who were selected for the TCA studies, hence the reason why the TCA studies looked like they're slightly more efficacious than the SSRI studies. And then there was a Cochrane review done by Gabbio and company. And what they found with that was that they also said that SSRIs were beneficial for the treatment of alcohol use disorder with or without depression. around it. For those of you who know Cochrane reviews, they never find anything that's of significance. Every Cochrane review that I typically read is like, there is no difference between it. There's not enough data for us to make a decision around this. They actually said that there was enough data to suggest that SSRIs. So somehow the CMAJ panel ignored these two major meta-analyses. And then they also focused on, this is my final slide, the Charney study. So Dara does great work in Montreal, and what they did was they looked at people who were admitted for alcohol use disorder, and they put half of them on placebo, half got on citalopram at a dose of 40 milligrams daily. So they were immediately started on 20 milligrams. Within 1 week, they were on 40 milligrams per day. Only about 20% of these people had very mild depressions. Their HAM-D scores were 8 on average, which is just outside of normal. And their Beck depression scores were around 13 to 12. So these people had very mild depression. And ultimately what they found was that the group that was getting citalopram was actually doing a little bit worse. Everybody got better, but the people who got placebo did better than the citalopram group. And so this interpretation was maybe it's actually harmful. Well, and it's kind of the way that you interpret it is, if I put somebody on a blood pressure pill who didn't need it, if I put them on a PPI who didn't need it, if I put them on an antipsychotic who didn't need it, they're going to have side effects from it. They're going to do worse overall. So I think the key is you wait for the person, you figure out what the diagnosis is, and then you start the treatment if you think that there's a moderate to severe disorder. So this is what our recommendations are, and then Jen's going to go into more detail. So think about it on a case-by-case basis, sort out the diagnosis. If you are going to use an antidepressant, probably the best data is for sertraline with or without naltrexone in this comorbid group. And then there's a certain number of people in the mirtazapine might be okay. I have more success with my male patients than my female patients just because the weight gain potentially with that. But there's a theory with people with more early onset alcohol use disorder is that serotonin reuptake is already maximized. So if you give them an SSRI, you just induce akathisia. And mirtazapine gets at serotonin through the back door. It's a 5-HT2 antagonist. And it acts on the post receptor. I might be blocking that, might be pre-I anyways, but it acts out in a different way. So there is theoretically potentially a better way to go about it with that group for mirtazapine. So if I have a person who has a lot of anxiety or sleep issues, that's the agent which I tend to pick if they're male. You have to address both at the same time. And then if you are going to start an SSRI, start low, go slow, and monitor for akathisia. Because a lot of people, I put them on just a tiny dose and they're restless, and all of a sudden it looks like anxiety. They're probably not going to have a good outcome with that agent. So make sure you go at a paced rate. And I'll leave the rest for Jen, and then we'll do questions after.
Thank you. Just because I'm curious, who here works in an addictions setting? Who here works in a psychiatric setting? Who here works in a concurrent setting? Okay, like you can't all work in all of them. I'm sorry, guys, but we have a big mix here, and I think that's useful. As Dave said, last week we spoke on this at the Canadian Psychiatric Association. I focused my comments much more on the addiction treatment because it was primarily a group of psychiatrists less familiar with that. So what are we going to do? I'm going to come back to this case, which I have to say I thought was a fairly complicated case, because I do think it represents the type of person you're likely to see in a concurrent disorder setting. And what I did from there is I distilled that. And the bottom line is we've got a 46-year-old guy, you can't read the notes, who's had a lot of losses due to his drinking, and has depressive symptoms. But I have lots of questions from this case. How much is he drinking? Are his depressive symptoms primary or alcohol-induced? What does he have in the way of psychosocial supports? Does he have coverage if I want to prescribe meds? And is he ready to make changes? And practically, I need to know all of those things, regardless of what recommendation 13 tells me. So I took a look at Dave's chart, and then I went back and looked at the case to see which sort of categories he fit into. And this is what I found. It's a wash. There's some of both. And this is often the case. This is not unusual. And then it begs the question is, does it matter? If it's a complicated situation like this and initial interventions have not led to improvements in mood and reduced alcohol, why not treat both in the hopes that it helps? Because at this point, differentiating primary from alcohol-induced may not help you in terms of sorting things out. I will not belabor this point. You guys know how to assess for alcohol use disorder. I think it's key to use standardized assessment tools to measure the amount of alcohol use so you can follow it over time. The audit is an excellent, non-judgmental, easy to administer assessment tool. You can give it to patients for self-complete, or you can ask the questions yourself. The first 3 will tell you what stage things are at or how many more questions you need to ask. And then to take the responses and from your assessment and determine if a patient meets criteria for alcohol use disorder. Again, because many of you work in addiction settings, I won't go into this, but hopefully your assessment will determine if they report impaired control over use, social impairment, risky use, and pharmacological dependence. You only need 2 symptoms to meet criteria for a mild alcohol use disorder. And I suspect I am preaching to the converted in terms of assessing the patient for where they're at and making changes in their amount of alcohol use. And one can ask patients what's good about drinking every day, what's not so good. Do I sound like Peter Selby yet? Because I should. I learned this from him. And then how important is it to make changes in your alcohol use? And how confident are you that you can make changes? Because that allows you to determine where a patient is sitting in Prochaska and DiClementi's cycle of change and needing to tailor your intervention to their stage of change. And I know this is a bit beyond things, but I think it does apply, a bit beyond the recommendation 13, but it does apply to working with your patient and determining how best to assess them. If they are really ambivalent about becoming more active and starting to make changes in their alcohol use, you can tailor different interventions than if someone says, listen, I've lost so much, I'm ready to do whatever it takes, help me, doc. They're at a different stage and you would offer different interventions. Again, because so many of you work in addictions, I don't need to go over the multifaceted options there are for treating someone with alcohol use disorder, including mutual support groups, talk therapy. We have lots of evidence-based interventions, both individual and group, treatment programs of increasing intensity, and pharmacotherapy. From the concurrent disorders literature, you are likely familiar that there are different strategies for working with someone with concurrent disorders, in this case, depression and alcohol use. Are you going to go with serial treatment? Treat one disorder, then the other. But which one would you start with? If you treat the alcohol use, but they're really depressed and that doesn't get better, or if you treat the depression, but they're still drinking every day, so that tends to be less successful. A parallel treatment refers to treatment of both at the same time, but in separate services or programs or clinics. Better than nothing, absolutely, but without any communication between the 2 different approaches, that can be confusing for patients, and different programs could have different philosophies, right? Abstinence-based treatment programs may may be a struggle for a patient if their physician is recommending medications. Not so much anymore, but there certainly was a time when that was difficult. Ideally, someone would receive integrated care from a program or clinic that provides care for both conditions at the same time. I realize there's not a whole lot of those clinics. There certainly are more and more all the time. And I think we can look at the idea of being, I'll say, concurrent friendly, if not fully integrated. Again, I don't need to tell you about non-pharmacological treatments. I made this slide up for non-pharmacological treatment of addiction and then looked at the interventions and realized, hey, that's behavioral activation. When someone comes to me depressed, I say, listen, can you go for a walk every day? Can you get out and figure out what could you put in your life to meet with a friend or do something meaningful or pleasure, enjoyable? And the same is true for treatment of substance use disorder. And of course, these interventions you could offer as an individual from your practice, but also work within clinic settings, and most of them are low cost. Those two books there, Alan Carr has a huge series of books. They're essentially CBT in a book and helped lots of people. And Get Your Loved Ones Sober is community reinforcement and family therapy, helping families to introduce essentially a contingency management program that can be helpful so that families feel that they're not just nagging, they're supporting someone through recovery. Before I go on to meds, there is, in addition to talk therapy and all that other stuff, there's an increasing array of apps and an increasing array of websites that some have a small cost, many are low cost. In the middle is the Concurrent Disorders Clinic I work with. We have developed a series of virtual therapeutic drop-in groups because people with concurrent disorders tend to live lives of chaos, and if they're ready to make change, I don't want them to wait 8 weeks to start a 12-week treatment program. Here they can just drop into our group each week, each day, if they're ready for it. But I want to make it clear that there's lots of other options available. And I do all that because the medications for alcohol use disorder were studied within the context of talk therapy. The doctor didn't just say, here, take these pills, you'll stop drinking. It was done within the context of motivational enhancement-based interviewing. By and large, and different sorts of talk therapies. However, again, I'm preaching to the converted and likely will not go into this in detail, but we have excellent medications for treatment of alcohol use disorder. Excellent's probably too strong a term. We have 2 medications with the Health Canada indication that have good outcomes, but of course don't have everyone, and we have some off-label meds as well. I'm sure you're familiar with naltrexone, and recent data suggests that number needed to treat of 12 or less, which is way better than things like blood pressure and cholesterol meds, right? Way, way better. So it doesn't help everyone, but does help a lot of people. And I usually start with naltrexone. I'm sure you do too, because it's 1 pill a day, right? As opposed to acamprosate, very different mechanism, 2 pills 3 times a day, possibly slightly more effective than naltrexone. And again, the number needed to treat of 12, possibly less. Again, phenomenal outcomes compared to many things, many medications. And I think it's key to recognize that if someone does not respond to naltrexone, it's worth trying acamprosate. We also use some medications off-label, gabapentin being one, although David Marr's colleague, when we've spoken in Montreal last week, was less than enthused about gabapentin. I find it helpful for people for sleep and reducing anxiety, at least for a little while. So we've talked a little bit about alcohol use disorder interventions. What about medications? There are, of course, many antidepressants to choose from, and I'm going to suggest that I agree with Dave with that I don't like recommendation 13 and don't follow it. Although the population I see usually has been through several less intensive interventions before they come to me with alcohol use disorder and depressive symptoms, and they've tried the non-pharmacological things. I tend to use sertraline as my first line because you can start at a low dose and go slow. I generally would not start with an SNRI because they have more side effects, right? To stay away from the tricyclics and the MAO inhibitors. And there is some use of the atypicals, particularly as second line or as augmenting agents. And I think, at least from my perspective, that SSRIs have very good safety profiles, that if less intensive interventions have been ineffective in helping someone to stop drinking or become less depressed, that they're definitely worth a trial. And I will prescribe those for patients. Of course, there are different times when you could start the antidepressant, depending on your practice and the patient's preferences. Do you start them while they're still drinking? Do you wait till they've abstained for a while and see if their mood improves before that? Do you start them at the same time as an anti-craving med? Or do you start the anti-craving med, see if they stop drinking and what happens to their mood, and then start the antidepressant? I don't have evidence or a great answer for that. I think it is worth thinking about. In the practice setting I work, generally I would start both of them together, but then my patients have been through less intensive interventions at that point. But I don't think there's any right or wrong or best answer. Right now we don't have that evidence to know what's best. So I would probably start sertraline and naltrexone plus or minus gabapentin. And what do I do if there is a poor response? And poor response means several weeks, and it could mean different things. Are they still drinking? Are they still depressed? Or both? Because there's lots of things that could happen, right? And I think there are lots of options after several weeks of sertraline titration and naltrexone 50. Do you go up on the antidepressant? Do you augment it? Do you change it? Do you increase the anti-craving med? Do you push for greater involvement in addiction treatment? Do you reevaluate the diagnosis? Or use increased motivational enhancement strategies to encourage someone to reduce their alcohol use? I can't tell you. I mean, it would depend very much on the situation and the case, which one of these you would choose and would go with. I just wanted to list them to make sure we sort of thought about the different options that are available out there, and that hopefully in the next years we'll have better evidence to guide us in which way to go. And with that, I will summarize that I think our recommendations are to recognize that depression and alcohol use disorder are chronic illnesses, and we do have effective treatments that should be offered to patients. Behavior change is really hard, right? Particularly when coupled with an addiction, and the patients have so much guilt and fear stigma, particularly with depression, right? That just kind of amplifies all of those negative feelings. I encourage integrated care, use of motivational enhancement strategies, and treating both conditions, I'm going to say assertively, depending on the setting. In my setting, I would treat both at the same time, generally, but it also depends on a case-by-case basis. Encourage activation, behavioral activation, and support and encourage any success, reductions in alcohol, reductions in symptoms, increased behavioral activation. Thank you very much for your attention. Some resources here, and we even managed a few minutes for questions. Thank you. I don't know if we have a mic, so either talk really loud or come on up here. Good.
In his case, and like ones, I'm less likely to prescribe. I like to wait, and particularly if you have a guy who you're not worried about suicide risk around, that I'm going to pause. I'm going to focus a bit on his alcohol. I'll be talking about, yes, I'm concerned about your mood and so on, but as long as you're still drinking, it's going to be really hard to treat your depression and to really sort of, incentivize the reduction in alcohol use. Talk about, I would add in a little bit earlier, probably something like naltrexone for him, particularly if he has a fair amount of cravings. And then if they continue 2 to 4 weeks after, and there looks like there's significant depression despite efforts to kind of reduce use, or that they have brought down, I'm going to talk about adding an antidepressant. I would specifically ask the person about what agent that their family member who had depression, what did they respond to? Because that'll also give you guidance, because things tend to fall in families as to what people respond to. I don't know if you're different in that way.
I would probably work on a similar timeline. And I have the luxury is not quite the right word, but I work in a clinic with several clinicians who do much of the initial assessment, work with the clients individually, and we have this robust virtual drop-in group program. So patients initially start with that. By the time to come to me, if nothing's getting better, let's say I prescribe both, I would see them at 2 to 4 weeks, depending on a number of factors. And I'd certainly adjust medications in a month if I had not seen a response. If I'm worried about someone, if they're high risk, I'll certainly see them at the 2-week mark, and the clinicians can check in with them every week.
Thanks for the review. I found it very helpful. My question is to do with heavy drinking days. I thought the controversy was around using SSRIs, and that actually triggers more heavy drinking days, and I thought that came from RCTs. When you were saying, the evidence is that people are doing well whether or not they have concurrent alcohol use disorder, my memory goes way back, and I thought it's always been a predictor of non-response to antidepressant therapy if you have depression with alcohol use disorder versus if you didn't have it. So that was kind of new. But my bigger question is, can you comment on the findings? And I think it was from RCTs on heavy drinking days being more with SSRIs.
Yeah, and that was the Charney citalopram one. And so overall, both groups had less drinking than when they first came in. They all improved. The group on citalopram did have more heavy drinking days when none of these people got treatment for depression at all. So they were solely getting treatment for alcohol with it. And they were all comers who were being put on an SSRI. So they didn't only put it on the people who are depressed, they put everybody on, or half the people on SSRI, half on placebo. And so that's where the issue is. If you put somebody who doesn't have a depression or an anxiety disorder on an antidepressant, what do you think the outcome is going to be like? I mean, if I took a medication which I didn't need, I'm probably going to feel worse. And then you could see how it could potentially spur that on. So that was the one study which showed that. There's other studies which don't show that around it. So I think the particular issue with that study was that they just jacked the dose right away. So they were on full dose. They were actually maximal dose at week 2, rather than most people, if you have them admitted, that you would sort of watch and then see if there is a significant clearing, that you focus on the alcohol, and then only add it in if it's a moderate to severe depression at that point. But none of the people enrolled in that study had anything more than mild depression. Yeah.
I also think if someone comes with both symptoms or with both conditions, that I would treat both. If someone's drinking heavily and depressed, I would not just give them an SSRI. I would say we've got to do both here, an anti-craving and an SSRI or an antidepressant.
No, you don't have to say, oh. So I just want to comment on David's comment. Because
it's a big group.
Well, I'm pretty loud. The Charney study is from my site at the McGill University Health Center, and many people have interpreted it as David had talked about it demonstrating that SSRIs drive people to drink. So it's not just the way that they didn't do as well as the placebo group. The idea is that it actually drove people to drink, and I think a lot of emphasis has been put on this study for recommendation 13, and it's a single study, and I think that's a mistake. And I think even from my perspective, even though this was our study, it does not really jive with what I've experienced over the course of my career, and it has not informed my prescribing habits or how I treat patients. And so I think it's really unfortunate that it's such a driver in these recommendations, which I personally think are misguided, and I think are potentially problematic. The recommendation 13 tells you very clearly what not to do, but there's no recommendation as to what you should do. And so, we're potentially, I think, withholding care from people that really might tremendously benefit from it. So I think it's just taken on a life of its own that's a bit problematic.
Yeah, and I would add to that is that the outcome of it was that people would show up in detox and be immediately discontinued from their SSRI and then crash and burn soon afterwards. And so it's, if you do have a person come in, they're on an SSRI, do consider whether in fact the SSRI might be making matters worse. I have no problem with that. Like, think about, is it driving akathisia? Could it be contributing? But also ask why they were put on it and whether it's been beneficial before it gets stripped off, because people end up having discontinuation syndromes, as well as their mood and their anxiety can get significantly worse, which then all of a sudden we know that that's associated with worse drinking outcomes afterwards. Yeah.
I think we're at time. I think
Yeah.
we're at time. We'll call the session, but Dave and I will stick around. Thank you very much for your attention today.